of your heart, baby. The beating of your heart, baby.
We're in the cardiac setting. Dr. Kuby is set it for the application cardiac. Using the phased array probe, the P21, a footprint of 21 millimeters. She's in the cardiac setting, but we're doing with the leading edge, that is, the mark is on the left side of the screen. We are pointing toward the left hip for the long axis. The long axis, if we hit the pictograph, we can view back to number 1, scroll back, and get the long axis picture. In that long axis, we can see anteriorly, we'll see the right ventricle, then we'll see the interventricular septum, then the left ventricle. If we move down to the receding edge, we can see the left atrium. If we move down to the receding edge, we can see the left atrium. It's going to be posterior to the ascending aorta. It goes through the anterior and posterior leaflet of the mitral valve into the left ventricle, and the blood flows out through the aortic outflow tract. Dr. Kuby is visualizing this long axis by getting the aortic valve and the mitral valve in the same plane. Thus, we are in the long axis with the apex as a landmark is displayed on the leading edge. On many images, you can sweep the probe and look for the descending thoracic aorta. It will be a circular anechoic structure that will be posterior to the left atrium. On many images, you can sweep the probe and look for the descending thoracic aorta. It will be a circular anechoic structure that will be posterior to the left atrium. On this image, we are just seeing a mirror image artifact of the heart as the pericardium acts as a mirror image. So actually on this view, we can see, now we've seen the descending thoracic aorta come into view. Here is a circular structure posterior to the left atrium. If we do see fluid, if the fluid it collects anterior to the descending thoracic aorta, it's pericardial, while if it goes posterior, it'll be pleural. There's no fluid on this image as we see the hyperechoic pericardium next to the posterior wall of the left ventricle. Instead of gray-white, you would see gray-black-white. You can also look at contractility, and you can notice that the walls are squeezing. They're squeezing symmetrically. It looks like no gross wall motion abnormalities. As Dr. Kuby switches to the short axis, she'll change her pictograph. She'll rotate the probe 90 degrees, now with the probe pointing toward the right hip. On a plane from the left shoulder to the right hip, she's still in the peristernal short axis. We can visualize the short axis. The left ventricle will look like a circle. Within that circle, we'll look for landmarks. If we see the landmark of the mitral valve, we'll know we're at the base of the heart. The mitral valve, or fish mouth, will go across the left ventricle. She can pivot the probe and image the papillary muscles. That is the landmark for the mid portion. As you're watching this image, you can put a mental finger in the middle of the left ventricle and see that all the walls are concentrically squeezing toward that. And then as she pivots the probe even more distal toward the apex, there is no landmarks within the circular shaped left ventricle, and we are now at the apex. And then as she pivots the probe even more distal toward the apex, there is no landmarks within the circular shaped left ventricle, and we are now at the apex. She can then pivot the probe back up through the mid portion, looking at the papillary muscles all the way up to the mitral valve, and then try to image the mediastinal view, which is number 5 on our pictographs, and we can see the aortic valve. This has typically been called the Mercedes-Benz sign because the valves, the 3 leaflets of the aortic valve, the right, left, and non-coronary cusp look like a Mercedes-Benz. Posterior to the ascending aorta will be the left atrium. Anterior will be the right ventricular outflow tract. Next to the left atrium will be the RV. So you have the aorta, ascending aorta in the middle of the screen. You have the left atrium, the right atrium, the right ventricle, and at times you can see the pulmonary artery, but not on this view as there is obscuration secondary to lung shadow. That is the short axis peristernal views. As we notice on Dr. Kuby's technique, she has her small finger balancing her self on the patient's chest. And that's key when you're doing your cardiac imaging, is to have a good probe position and holding the probe like a pencil and having a good balancing a finger with the landmark. We can now image the apical 4-chamber view. Using sufficient gel, we can put the probe down near the PMI. As you see, Dr. Kuby has the probe pointed toward the right hip with the indicator pointing to the right hip. She's balancing herself on the anterior chest wall with her fingers. She visualizes the beating left ventricle, and then she tries to manipulate the probe so that she can get all 4 chambers in view. A lot of times this is a oblique cut through the cardiac structures. In the way that the image will be displayed, we will have the left ventricle on the receding edge and the right ventricle will be on the leading edge. Of note, when you start to sometimes see the right ventricle, you can rotate the probe and open that up. And then a little bit lateral. And then I think if you just go like that, yeah, like that. Hanging up. You can visualize the left ventricle to right ventricle ratio. You can measure these at the valve tips, at the mitral and tricuspid valve tips, measuring from inner wall to inner wall. And this diameter of the left ventricle to right ventricle is normally a 1 to 0.6 ratio. With acute and chronic pulmonary hypertension, this can be a 1 to 1 ratio. Nice. Nice. And when you get the image in the correct plane, you can see both left and right ventricles, the interventricular septum in the middle of the screen, and you can see both atria, and you can see the mitral and tricuspid valve. When you visualize this view, you can try to aim anteriorly just a bit with the probe and the aortic outflow tract. And at times we visualize this as an apical 5-chamber. There it comes into view. Many times these views are obscured by the expansion of the lung and the air interface. There we go. Another common view is a subxiphoid. You can move the probe with the probe pointing off over toward the patient's right side. We can put the probe in the subcostal margin. As Dr. Kuby is demonstrating, you put in the probe, holding the probe on the cephalad surface, putting the finger down to put downward pressure, trying to get in that subcostal margin, aiming up toward that right shoulder, getting the liver in the near field, following the IVC, and flattening the probe out to actually visualize the subxiphoid or subcostal view of the heart. On this view, you'll see 4 chambers. The chambers that are next to the heart will be the right heart structures, the right atrium and the right ventricle. And the structures on the receding edge will be the left ventricle and the left atrium. You can have the patient take a deep breath and hold that to try to push the heart structures closer to the diaphragm.
Pull out completely.
And one of the landmarks is the antler sign. As she verticalizes the probe, coming back, you can see the IVC with the middle hepatic veins drain into it, and then the IVC going through the diaphragm into the right atrium. Thus you have a way to interrogate the heart in 4 planes, a long, short, apical 4, and a subcostal view. This multiplanar approach will give you assessment of the pericardial fusion, gross contractility, and allow you to see multiple walls from multiple planes.
That's nice.